Hello. Welcome everyone to another live stream. Good to be here and good to be back after a couple of weeks off. Pardon me. Still can't kick that little cough. So for those that don't know, this is Generally Practicing, a live stream which I'm hosting hopefully every Wednesday to talk through various aspects of general practice to get you ready and further through your general practice career. My name is Kane Treble. I'm a GP registrar currently based out of Mildura, Victoria, northwest Victoria. And I am nearing the end of, hopefully, my registrar years. I've just sat the KFP exam. I'm awaiting results and getting ready to handle the CCE. But I thought I'd take a little bit of time and reflect on the journey that I've taken through to get me through fellowship and spend a bit of time talking about the things that I really wish someone had sat me down and talked to me about before I'd started general practice or in those early days. So I can see a couple of people in the chat here tonight. Welcome. Great to have you back again. Feel free to throw some comments in, and if you are a GP registrar or GP yourself or interested in entering the general practice pathway, feel free to throw in some questions and we'll try to get through as many as we can tonight. So, without further ado, let's get into the presentation and let's hope I push the right button here. Here we go. Oh, let's not break it. Oh, I broke it. Fair enough. Let's get the presentation on the screen, and there we go. So, a rough rule of thumb for the things I wanted to cover tonight, what I wish I knew when I was starting general practice, some tips around communication, dealing with uncertainty, Medicare billing, care plans, health assessments, mental health, both patients and our own, quick chat on dermatology, aged care and home visits, paperwork and reports, which is the red tape bane of my existence, as well as covering pay as well. So, to kick things off then, the first thing I want to point out is that if you're considering general practice as a pathway or in those early days and unsure if this is for you, I want to highlight general practice is awesome. It is an absolutely fantastic career. It is the most rewarding thing I've ever done in medicine in Australia, but it certainly is challenging. I don't think I've had more fatiguing days than those days where you may, for whatever reason, see 40 patients over a day and you come home just physically and mentally tired. It's also a very unique career line in that you're in the community setting, and it's one of the few medical kind of pathways that does specialise in community-based care, which does give you a lot of unique challenges and opportunities as well to pursue. And something that I think is really worth reinforcing is the fact that general practice can become anything you want. If you have a special interest in some little niche area, there's a good chance you can do that as part of being a general practitioner. Yeah, of course, there's going to be issues where some things just won't be practical in some settings, but by and large, you will find the ability to adapt your career to any other aspect of medicine as well as general practice if you are so inclined. So with the good stuff out of the way, some of the things that I really wish had been highlighted with me, perhaps a little bit more, is to make sure when you're starting, and in particular when you're starting your GPT-1 rotations, this is where you're a baby GP. This is when you're first seeing patients on your own. You've come usually from the hospital setting. You may not have actually had that much experience in the general practice setting previously. Really, really important to establish those really clear communication channels with your supervisors. And a part of that would be setting up a frequency for meetings so that you have an idea of when, how you'll be catching up with your supervisor, as well as setting those expectations for what are the things that you want to be tackling, because at the start, you're not going to know what you don't know. And so I really wish I had have spent a bit more time reflecting on that and getting that kind of regime down pat. Again, a big part of this is going to be getting that feedback from your supervisors and making sure that you set up a channel to get positive, constructive criticism and highlight if you're feeling like perhaps some of that criticism might be deconstructive or not helpful. a big part when I was first going through, and things are a little bit different now that the colleges have taken over the training programs, is looking at learning goals. And we used to have to do learning plans. I think there's still probably going to be some form of that moving forward. And I wish I had taken them a little bit more seriously, because I think particularly in those early days, again, you don't know what you don't know, and you'll start to pick up as you see patients, you'll say, oh, actually, I don't know much about that. And so giving yourself that kind of structured approach to tackle those topics is incredibly valuable. Likewise, if you come across those topics that you think, oh, I don't know if I could have done better there, I don't know if I know enough about that topic, jot those down and have those chats with your supervisor to let them know kind of the things that you might be needing a bit more help or support or even just direction with as well. Of course, make sure that if things do arise that you are tackling them promptly. Don't sweep things under the rug. That's when things will explode in your face. But try and maintain that kind of professional approach to all the things you do. Now, communicating with patients. General practice is a bit of a different beast when it comes to communicating with patients because you are able to develop those long-term relationships, I think probably better than any other specialty can. I've lost count of the number of times that a patient of mine will go see some world-renowned specialist that is the absolute expert in their field, and they'll see that person, they will give their history, have their examination taken, and a plan will be formed, and they'll bring it back to me and say, but what do you think? And that's an incredibly humbling, privileged and powerful position that I think reflects how much trust our patients put into us. So because of that, I think one of the best things I can advise is spend more time listening to the patient than talking to the patient, he says while blabbering to a live stream. But you know, the principle stands. I think that I, particularly in the early days, felt like I needed to try and prove myself to the patients and to try and show that I knew what I was doing. And as I've become more comfortable in my role, I find that I really am spending most of the time listening, prompting little bits here and there, but really just listening and paying attention to what the patient's telling me, both verbally and non-verbally as well. A big part of getting that history out is the non-verbal communication and the things that the patient doesn't tell you. Again, try and use simple language, try not to use medical jargon, and a good approach I've taken too is actually using medical jargon or saying, you know, oh, look, the fancy word for this is, well, that's not the actual fancy word, of course, and then use some other explanation that can put it into context for that specific patient. There's the usual little caveats of practice empathy and cultural sensitivity. And I think as well, the more you stay in general practice, the more you realise that the empathy and that reflection of understanding and often just acknowledging a patient's condition is usually just what they're after. But a lot of patients with chronic pain don't necessarily need the big, powerful painkillers. They don't always need the referrals to subspecialties. Sometimes they just need someone to say, look there, that's really rough. You know, I wish there was more we could do, but hey, let's focus on this and try and get you moving forward. And of course, we have to respect patients' autonomy because there's going to be lots of times where we'll be coming up and saying, look, here's the guidelines, here's the recommendations, and sometimes tying that into the context and into what that patient's actually going to be able to realistically achieve can make or break a good GP experience. Now, we always talk about uncertainty in medicine, and boy, oh boy, is there uncertainty in general practice. We are that usual first port of call for undifferentiated presentations, and I think a lot of subspecialties perhaps forget what it was like to try and tease out the story that got them to the referral in the first place. Now, it's really easy in general practice because you're kind of put into an office usually on your own and usually kind of locked up for long stretches of time to start to perhaps deviate from standard practice. And if you don't have those evidence-based guidelines, those checks around you, people around you that you can run these situations and stories by, you can find yourself kind of sometimes falling off the normal standard pathway. And so it's really, really important to make sure that you are referring back constantly to evidence-based practice to make sure you are doing the best thing for your patient in front of you. Easiest way to do that, of course, talk to your colleagues, talk to the specialists in your area, talk to specialists out of your area for complex cases, and almost do your own little MDT sessions through the phone to try and make sure that you are actually doing the right thing. This is where often keeping in contact with friends and colleagues through other workplaces or through your hospital years can be absolutely invaluable. And I've lost count of the number of times I've phoned a friend literally to say, "Oh, hey, you're doing derm now, aren't you? Hey, what do you reckon about this?" And sending a thank you note or something afterwards to show that I appreciate their help goes a long way as well. Now, a part of this is to, from time to time, jot down those cases that you did find uncertain and reflect back and say, okay, well, what actually was that in the end? Did we work it out? And next time I see that patient or that case in front of me, what would I do differently to help try and tease out perhaps for that next patient that presents with a similar thing? And Medicare billing. Oh my goodness. Yeah. So I suck at billing. I don't think I'll ever be a rich GP, and I've made peace with that. And a big part of that, I think, is that Medicare billing is complicated. It is I don't want to say outdated system. It is a system that has been set up for one purpose and is trying to fit the needs of the world today, which I think is perhaps slightly different to the world as it was back then. So it is something that is definitely worth spending some time wrapping your head around when you first come into general practice. Now, there are lots of online courses and programs to familiarise yourself with Medicare benefits schedule. You can get, I know Business for Doctors is probably the most commonly used one, and I've seen lots of people that say they've had fantastic experiences from that course. I haven't done it myself, so I can't vouch for it personally, though I should probably try and get an affiliate code or something. I don't know. I think the important thing it does, though, is give you that structured approach and to get you to actually read the item numbers for the things you're billing to make sure what you're actually doing is going to fulfill those codes and that you're not going to, down the line at some point, as we all will, get an audit and end up in deep trouble. So it's really, really, really important to make sure you're coding accurately to avoid billing errors. And the tricky thing is that by default, our response to this is to then just dumb it down, so to speak, and to essentially stick to our time-based codes. Now, while that is a safe practice, it's not always the best practice, and certainly in terms of financial reimbursement, it is possibly one of the reasons why so many GPs are dramatically underpaid or receive a much lower income than a lot of other subspecialties. Tied into that, I want to mention, though, private billing, and we're in this kind of awkward transition in Australia at the moment where there's fewer and fewer clinics doing just bulk billing. So bulk billing is the term by which the complicated setup, again, an antiquated system, but essentially the Medicare rebates are what the government has agreed they will pay to cover the patient's medical needs. So when we talk about rebates, they're not our rebates that we get as general practitioners, they are the patient's rebate as to what the government thinks that should cost to get money back. Now, bulk billing is where the practice agrees that that is the fee that will be charged, and so the standard billing process is bypassed so that the government then forwards that patient's rebate directly to the clinic. And the patient signs a slip to say, yes, I'm happy that this occurs. In practice, that means that the patient doesn't receive a bill per se, so much they agree to sign over their benefit, their rebate to the practice in lieu of paying fees to attend that session. Now, there's private billing as well, which is where the clinic has dictated that actually we think it costs this amount, which is different to the rebate, and the usual practice that occurs here these days is that the patient is charged the full amount And that is then the information of that is sent to Medicare, and the rebate for that amount, which is a lesser value, then gets credited to the patient's account. So even though they're paying the full amount, they then usually almost instantly get that rebate amount added back to their account. Now, this has caused a lot of trouble in Australia because a lot of patients who perhaps were used to being bulk billed previously and not having that out-of-pocket cost now have to. And even though for a standard consult there may be $20, $30 out of pocket, in some places more, there is actually that much higher initial cost they have to pay before that reimbursement occurs. Now, again, there is the notion that healthcare in Australia has been free. Really, it's the government handling the rebates. In practice, for the patient, essentially they're not paying money to see doctors or receive medical care. And the way that the rebates have been adjusted for the last many, many years simply reflects that the government has not adjusted those to match inflation, to match rising costs of running a practice. And realistically, it's no longer viable to try and maintain a practice just off bulk billing. And the only way to really try and do that is to maximize the amount of revenue you raise through essentially seeing more patients, trying to rush through as many as you can, maximize rebates from things like care plans. And the fear, of course, is that we're then actually decreasing the quality of care that we are providing our patients. And for this reason, most practices now, I think, are charging private fees for patients coming in. That's a long-winded way of saying, if you are in a clinic that is charging private fees, I would strongly encourage you to bill privately from day one. And when I first came across, coming from a public system, I really didn't like the idea of charging patients. I held and still hold the belief that healthcare is a right, not a privilege, and that realistically the government should be investing in the population to keep them happy, healthy, so that they can go on to their workplaces, work in their jobs, pay their taxes, and the whole system then generates its revenue and money through that, and the cycle rinses and repeats itself. But sadly, that is not the way the world is working currently. And if we want to keep doors open, if we want to keep practices afloat, there are just going to have to be private fees associated with it. And sadly, that is just the way it is right now. Now, of course, to add an extra layer of complexity to this whole setup, the Medicare billing regulations and the codes that are used are changing constantly. And this is where speaking to your supervisors to get their understanding of things can be incredibly helpful, but also jump onto online forums, things like GPs Down Under on Facebook, a massive, massive Facebook group of GPs all across Australia can be really, really helpful because what it comes down to is sometimes the item descriptions don't necessarily seem to say the same thing as what everyone's opinion is, and trying to get clarification can be like pulling teeth. There is a service called Ask MBS where you can pose these questions to the Medicare and receive responses. The trouble with that, of course, is that the responses that are given aren't guaranteed to be accurate, and if you base your practice off those responses and get audited, there is a chance they may say, sorry, that doesn't actually stand, we disagree with what was said then, and you are liable. Now, there was a big kerfuffle not long back, as I don't doubt you saw, about GPs and doctors rorting Medicare, and this is a big part, I think, of what got missed from that discussion through to the public at least. It was definitely raised by doctors involved in this story, but the concern was that it wasn't adequately reflected that actually, if anything, GPs in particular, we're probably underbilling Medicare because we are sticking to our standard time-based codes to try and avoid getting audited for all the extra complexities and all the extra little bits that we could and realistically probably should be charging because we are so terrified of getting audited and being forced to then pay back money. So, of course, at the end we'll seek help from experienced colleagues, so people that have done proper billing, preferably been audited and passed or had as minimal paybacks as possible, or speak to billing experts. And as I mentioned earlier on, Business for Doctors comes highly recommended from most circles I have spoken to. Again, I have not done any of their courses myself, but a lot of people say that they have fantastic resources, so definitely where I would start my search. Now, tying into this is care plans and health assessments. These are things that you will see done that aim to take that holistic approach to look after the patient. The GP management plan is the main one most people talk about, or chronic disease management plan. This is when you've been in the hospital setting, that 5 free physio visits that you've probably spoken about, and unfortunately, they're not free, they're subsidised, which causes all kinds of grief for a lot of patients, but also you actually require very strict conditions to be eligible for these things. So again, I strongly encourage you all to read up the MEDICARE item numbers when you get into practice, 721, 723, the big ones you'll worry about there. But I wanted to focus on the fact that these then become kind of just billing items to try and maximise revenue, because they are big income earners for GPs doing these. And sadly, they can be a bit of a churn and burn to just try and get through as many of these as possible, just to try and keep things afloat. But they're actually fantastic opportunities to make sure you are developing comprehensive care for your patients. And they're also times, particularly in your early training, where you can guarantee you're getting massive chunks of time with patients to be running through each of their issues and making sure we are addressing them with a plan in place to continue to address those over the next 12 months. Now, tied into those is team care arrangements, where we tie in allied health professionals, and this is that subsidised visits to physiotherapy or podiatry or other health professionals. And I'm a massive, massive fan of just calling them directly on the day and saying, hey, I'm sitting here with patient X or patient Y, and we're trying to get a team care arrangement set up. Would you be happy to do this? These are the things we're trying to focus on. Are you happy if I send you through the paperwork and we get this moving ahead? I think the allied health professionals often really appreciate that kind of direct communication of, hey, this is what we're trying to achieve, this is why we're doing it in this way for this patient, and certainly closes that feedback loop for them. Now, part of this is to also regularly review and update the care plans. 1, there's financial reimbursement for doing this, and 2, make sure we're actually hitting the goals we're trying to set. As part of goal setting, we should be saying we're hoping to achieve this target by this time frame, and we have to hold the patient and ourselves and the other team members accountable for that as well. So good opportunities to actually intervene, step in and say, is this working, or do we actually need to adjust what we're doing? Of course, document care plan outcomes, communicate through to the patient, and if it's not written down, it didn't happen, which sadly, going back to the last slide, would get you in an audit. Now, next thing I wanted to talk about, we are on fire tonight, is talk about mental health, given it's something that maybe you won't have significant experience coming into before you get into general practice. And you will see an absolute variety of mental health conditions in community, and you will be responsible as their GP to continue the care of a lot of mental health conditions. So very important to recognise and start to pick up the little cues of common mental health conditions. In Australia, for example, probably the most common ones will be depression and anxiety. And so making sure that you have that as part of your usual screening algorithms and routines to make sure you're looking after patients. Very important to use validated screening tools. This is not only to identify and grade the severity, work out how worried or how cautious we need to be, but it also means you can then review patients between sessions and say, look, I can see these markers here are a bit high or a bit low. We're winning, fantastic. Or, hey, we need to catch up and work a little bit more in this area. For this reason, one of the tools I really love is DASS21, DASS21, which separates out depression, anxiety, and stress in the patient. So it's a really, really handy tool. If you're not familiar with it, look it up. It's on MD Calc, you name it, it's everywhere. Even best practice software now has it built into the software as well, because this is a really, really good way to work out what's happening in a patient's life. A big part of our role as GPs as well is to promote the destigmatisation of mental health. I'm working in a rural setting myself where we get a lot of the old stoic farmer types who were never supposed to talk about mental health. They grew up where it was taboo, it was not to be acknowledged, and we can do incredible things by just opening up that door and saying, oh, yeah, good, your blood pressure's fantastic, but how's your mood been? You've been feeling okay? You would be amazed how many times people kind of give you a bit of a glance and then say, oh, a bit rough lately, a bit rough. And that gives you that opening to explore then mental health with them. And of course, you've got your own mental health as well. General practice is a emotionally demanding job. You invest in your patients as much as they invest into you. It's important to make sure you have that kind of clinical separation still, but you will be seeing these patients again and again. You'll be following through from a baby's first immunisations to their first upper respiratory tract infection, all the way through to potentially their teens and later life if you're staying in the one area for long enough. So really important that you acknowledge that you make sure that you are protecting your own mental health, recognising signs of burnout. We can work very long hours. We can have extreme demands on us, particularly time pressures as well. So making sure we've put into place systems, mechanisms, ways by which we can manage our own stress. The best thing a GP can have is a good GP. Sounds like a self-fulfilling prophecy, but having someone that you can check in to look after yourself is absolutely invaluable. Make sure you do practice self-care, that you're trying to maintain work-life balance. General practice, the running line, pardon me, a lot of people go into general practice to get better work-life balance. And it's true. Compared to a lot of other specialties, we do have fantastic work-life balance, but we can still blur those lines sometimes and burn ourselves out. So it is important to make sure that, yes, we've got the best opportunities to achieve that. We need to be making the most of those. Workshops, in your early training, you'll have lots of workshops spread throughout, and there are lots of tips and tricks in there on coping with stress. And it's easy to kind of look at them and kind of say, oh yeah, one of these hand-holdy sessions. They're actually really good. Pay attention to them. They'll teach you some tips and tricks that can absolutely save your career. And of course, you are going to be not only giving those first immunisations for baby, you're potentially going to be palliating baby or palliating their parents or dealing with the worst moments of their life as well. So we see the very best. We also get the very worst. We give the cancer diagnosis. We give the bad news. And that definitely plays a toll on you. And sometimes it's not those big events. It's just the cumulative thousands of little things that just build up over time. And so again, as much as it's good to have your own good GP, it's also worthwhile to have a actual professional counsellor, psychologist, or formal kind of debrief pattern to just vent sometimes, get stuff out, and make sure that you actually are dealing with things in a healthy manner. As doctors, we unfortunately have a tendency to move towards things like alcohol or substance use to try and deal with the pressures of the work. And so making sure we're maximising our chance to use all those other options, I think, is invaluable. Onto a completely different topic, still quite superficial perhaps, dermatology. I was amazed at how ill-prepared I felt moving into general practice in terms of dermatology knowledge and skills. Because it's not something that's really covered in a lot of detail in medical school, and unless you've had the opportunity to take up rotations as an intern or HMO, or perhaps done time as a registrar before moving to general practice, a lot of people won't have had significant experience here. And it's a big part of what we do. We deal with a lot of skin cancers and a lot of skin checks. So it is quite useful to try and actually pick up a couple of courses or books or try to expose ourselves as best as we can to dermatology, because you're going to have a lot of people coming to you saying, oh, doc, what's this rash? Again, living in far northwest Victoria, we are a desert country up here, and so we deal with a lot of education around sun protection, skin cancer detection, and really it's really important to emphasise lifestyle modifications and adherence to treatment, in particular protection and prevention of skin cancer. because it can absolutely make or break someone's life later on. Just a quick note here, if you don't know DermNet, it will soon become your Bible. So DermNet's an Australian-New Zealand website. I think it's primarily New Zealand, actually, that has pretty much every single skin condition you can imagine, with some good references and guidelines to follow for investigation and management. All right. Powering through, guys. Aged care and home visits. Now, there are a lot of practices that now will just say we don't look after aged care facilities, and it's a massive shame. Again, I think a lot of this comes back to high complexity patients with financial hardship who perhaps can't pay private fees. And the truth is, the attendance fees to attend a nursing home, they're not fantastic. And so the only way to really make it viable for a lot of people is to have a cluster of patients all in one facility that they can visit and see all in one go, to basically give them a mini clinic session on that day. What I would say, though, is that if you do get the opportunity to do this, it can be, again, some of the most rewarding you'll find medicine, let alone general practice, because these are people that really, really need looking after. They're medically complex and very interesting. And so assessing their needs can be possibly the best thing you do. Tied into this as well, home visits I tend to reserve for either very young children that might have difficulty getting into the clinic. Say there's other family members unwell and it's just too difficult for the family, I'll consider doing home visits, but also palliative care as well. And this is something that I think a lot of GPs end up kind of dipping a toe into and finding a bit of a passion for. So home visits can be fantastic experiences, but I would say that safety is the number one priority. So if it's something that you don't feel comfortable doing, or if you are working in an area where perhaps you may not be safe, or there may be concerns around safety, I would just say don't do it. You need to be turning up to work day in, day out. You need to be able to know that you are safe to practice in the area you are. And so if it's something that you're not comfortable with doing, there is no shame in saying not for me, thank you very much. If you can do it safely, or if you can have someone, say, that comes with you, and to start off with, I think it could be worthwhile even seeing if a supervisor can come with you to, say, a nursing home facility. You're probably not going to be doing many home visits, but if you are, again, see if it could be done with other services there at the same time, just to improve the safety. And have a look at the holistic care approach to those visits, because you have the unique advantage in that setting to actually see not only how the patient is and do your usual kind of consultation, but you get to see them how they're actually existing day to day. So to pull the curtain back a little bit, I was a paramedic before I became a doctor, and the number of times I was amazed by how well a patient could present when they're in a hospital or clinical setting, dressed up, makeup on, looking nice and pretty, and you take them to their home environment and you realise, wow, they are not coping at all. There's debris or litter or food everywhere, and this person actually needs a lot of help, but they're putting that effort into their appearance while they are in a clinical setting to perhaps mask how things are going at home. Pay attention to those little things. See if there's medication scattered around and how organised the house is. See if there's trip hazards. All these things will not only look after the patient, but make you a much better general practitioner as well. And again, as I said before, consider actually doing these visits with other services there and have that multidisciplinary approach. I really love going out to patients' homes for palliative care visits with the palliative care nurses that do the home visits to see how we can all work together to maximise the care for that patient. Really, really rewarding stuff. All right, paperwork and reports. So, my goodness, the red tape. The number of reports you'll be asked to do is absolutely astonishing, and I've just remembered there's another report sitting on my desk that I need to get to in the next day or two. So you will be asked to do a heap of reports. try and get into a practice that works for you to actually get through them in an efficient way, whether it's setting aside a certain amount of time at the end of each day or every second day dedicated to that, or have trays set up so that you can keep track of different reports at various stages while you wait for perhaps other bits of information or assessments to come through. I really wish I had spent more time perfecting that routine when I was first starting out, because the sooner you get into that routine, the easier it becomes. Likewise, get familiar with the different paperwork that there is for billing and care as well, so making sure that you are being adequately reimbursed. The rule of thumb is if the patient's not in front of you, you don't get paid for it. But reports can be the little deviation from there that you can still charge for a lot of reports. It may just be that the patient pays out of pocket or the service requesting the report pays out of pocket. You can use electronic health record systems to streamline paperwork. The government has tried to set up nationwide systems. It's not gone fantastic, if we're honest. But we are hopeful that will improve with time. And certainly a lot of hospitals are using electronic medical records these days, and some sites actually have the potential for GPs to have access to those to check their patient discharge summaries or medical reports, for example. Tied into that, do read the Medicare item numbers, do read requirements for reports to know what you are needing to write. If there's ever any doubt or you're not entirely sure if you're meeting all these standards, I would actually touch base with your medical indemnity provider and see if they're able to offer some advice or guidance. At the end of the day, you don't want to be putting anything down on paper that you wouldn't be testifying to in a court of law, because a lot of reports, that's exactly why they're being written, to provide legal evidence towards some situation. My rule of thumb, and a little bit embarrassing, but hey, don't tell anyone, this is between friends, right? I picture ending every single sentence I write into a report with "Your Honour." And if it's not something I would say to a judge, then I kind of say, oh, okay, well, how do I need to reword this to make it sound a bit nicer or be a bit more accurate, perhaps? That's my technique. There we go. Again, if there's any doubts, speak to your supervisors, speak to colleagues in the clinic, and come up with that plan of attack for you. Almost at the end, guys. Wanted to finish up talking about pay, because it is a bit of a topic that's worth covering, and is something I know a lot of people worry about when coming into general practice. Familiarise with general practice pay structure and agreements. There is a lot of variability clinic to clinic. What you'll most commonly see is a base rate and a percentage of billings agreement. So most of the time this is you agree that you are to be an employee of the clinic, and you'll be paid either a base rate, a base salary, which will vary clinic to clinic but usually goes by award rates, or a percentage of your billings, whichever is higher. That means you're essentially guaranteed to have income week to week. Let's say you need to take some sick leave for whatever reason. You're still going to have that income there, but it may be not as good as you would generate through billings alone. Now, the amount of percentage you would get is incredibly variable. It will all be up to you to negotiate to your clinic, and I'm not going to say what's good or what's bad. It'll really be up to the situation you're in. Bearing in mind that may change based on whether you're in a fully bulk billing clinic, in which case I'd be wanting a higher percentage of my billings given the overall amount will likely be less, versus a predominantly private charging clinic where you might be happier to have perhaps a slightly lower percentage given the overall billings likely to be a bit higher. Of course, we're going to try and maximize the percentage that we get to make sure we're earning as much as we possibly can for paying our own bills. We have our own lives as well. Now, the reality is we are paid less than most other specialties. In fact, we are the lowest paid specialty according to previous studies, and that is just the nature of the beast in general practice. Having said that, you're not going to go hungry. You're going to be able to pay for nice things, have a nice house, nice car, send the kids to nice schools. It may not be extravagant, but you're certainly not going to go hungry, and you can live extremely comfortably as a GP in Australia. Tying into this, and I guess coming back to billing practice as well, and why it is important to make sure you are charging privately from early on, Case in point here, we had a leak in the shower a little bit back, and called a plumber out. You call for the expert with the knowledge, with the expertise, and they fixed the problem within 15 minutes and charged us several $100s. Now, I think that's a pretty good way to look at what we're doing as well, because we often do have relatively short time periods with people. And I can tell you now, I'm not charging several $100s for that 15 minutes, but that's what I was happy to pay to have someone that knew what they were doing fix that shower so that I did not have to do it. And I can tell you now, I value my body much more than I value my shower. And so again, it is that investment in yourself, your body, your physical well-being. And for that, I think patients are becoming now more accustomed and more willing, maybe not happy, to pay those fees. So tied into that though, always check your pay packets. Not to say that it's intentional, but accidents do happen and you want to make sure that you are actually being paid properly. There is the potential in most software packages to actually run reports of your billings for each day or each week or each fortnight and compare that to what you think you should be getting in your actual pay packet to see if there's any discrepancies. Tied into that, I think, as well, is make sure that you understand if there is specific things that might influence pay, sick days or study leave. Your percentage will be based around your experience, your location. You should have a chat about these kinds of things to start off with, and pay expectations is a really, really big one. Something that may not seem that important at the time would be pay cycles, and my general advice is try to get fortnightly pay cycles if you can, as the longer the pay cycles run, the greater the potential for your percentage payments to decrease. There's a bit of math that goes behind that, but the rule of thumb is, trust me, you want as short pay cycles as possible. There can be substantial pay differences if you're having monthly or 3 monthly pay cycles, as some places still do. Be aware of different financial support programs for doctors in training and incentives as well, particularly if you're working in rural areas. There's still some incentives around. Check RWAVE, Rural Workforce Agency Victoria is the Victorian one, but there are different states will have their own branches and different programs as well. And don't be afraid to come back after a year or even 6 months if you're particularly keen, to bring that back and say, hey, look, I've been working here for a while. I can see I've made these kinds of improvements in myself. I'm more efficient in these ways. How about we have a chat about that percentage or my pay situation? Do you think we could have some room for negotiation again? I wouldn't be doing that every 6 months per se, but bear in mind that it is your pay at the end of the day and you want to be reimbursed for the work that you are doing. All right, so that was the last bit of presentation I wanted to run through today. Thank you guys for joining me in here tonight. If you have any questions, throw them into the chat. If you have any comments, queries, throw it down below and I will endeavour to answer it as quickly as possible. Otherwise, it's been another fantastic Wednesday. To peel back the curtain a bit, I am very tired tonight. I had my 2-year-old wake up at 4 in the morning. His first words to me were, "Daddy, why eat my chicken nugget?" Which I don't know what on earth he was dreaming about, but boy, to spend half an hour in his brain, and we were essentially awake from 4 o'clock. So feeling it a bit today. Thank you for bearing with me, and yes, I've still got that stupid little cough that I cannot flick. But I hope you're all having a great week, great night. Thank you for your time. And obviously, any questions, any comments or queries, reach out and I'll get back to you. Have a good night, everyone, and I will see you at the next live stream, which hopefully at this point will be next Wednesday, same time, 8:30, and I look forward to seeing you there. See ya.